Hmm. So what is the arteriosclerosis? Arteriosclerosis means that there is a hardening of the wall of the vessel. So there can be thickening and the loss of the elasticity of the arterial blood vessel wall. It has three patterns. One pattern is the atherosclerosis, other is the Mogdiberg medial gastric sclerosis, and third one is the arteriolosclerosis. In our previous lecture, we have discussed about the arteriosclerosis, and today we are going to discuss about the atherosclerosis. So what is the atherosclerosis? It is characterized by the intimal lesion, which is called the atheroma. It is protruded into the lumen, causing the obstruction of the vascular lumen and weakening of the underlying media. So atherosclerosis, this is an intimal lesion. In this picture, you can compare a normal vessel with a diseased vessel. In the normal vessel, the lumen is unremarkable, while in case of the diseased vessel, there is an intimal lesion which is going to cause the narrowing of the lumen of the blood vessel wall on the right hand side, and it is also going to cause the weakening of the underlying media. So if we talk about the atherosclerosis, this is a globally distributed disease with a serious complication. It is going to contribute almost half of all death in the Western world. And ischemic heart disease, it is responsible for about 25% of the total death in the US. And morbidity and the mortality, which is related with the atherosclerosis, it is also rising in the East. The atherosclerosis, it is having a high rate in the developed nations like North America, Europe, and the US. It is having the 5 times more disease as compared to the Japan. It is less prevalent in the South America, Africa, and the Asia. In the US, the 70% of the mortality, it has been decreased from the 1960 to 2000 because they have changed the lifestyle, prevention of the atherosclerosis because of reduced smoking, altered dietary habits, control of the cholesterol, control of the potentially controllable factors, and prevention of the recurrence. The risk factor of the atherosclerosis, these can be divided into the modifiable and the non-modifiable factors. Among the modifiable factors, these can be the dyslipidemia, this can be hypertension, this can be diabetes or smoking, while the non-modifiable factors, which can include the age, sex, genetic factors, familial and the racial factors, and the other emerging factors, which can be the environmental influences, obesity, hormones, physical inactivity, stressful lifestyle, hormone cystinuria, and intake of the alcohol, prothrombotic factors, and infections like the chlamydia pneumoniae, herpes virus infection, and high level of the C-reactive proteins. Amongst the non-modifiable risk factor, the age, it has a dominant influence. The atherosclerosis incidence, it is going to rise with the increase in the age. So the risk of the incidence of the MI, it is increasing 5-folds between the 40 to 60 years of the age. The males, they are more prone as compared to the female, and it is uncommon in the females during their reproductive life, but after the menopause, the incidence, it is going to increase, and it equalizes in the 7 to 8 decade of the life. The genetic factors, they do influence the development of the atherosclerosis. There's familial predisposition of the atherosclerosis development, and there can be it can be multifactorial disease. Like if the patient is having the increased risk factor of the diabetes or hypertension, there is increased chances of development of the atherosclerosis as well. Other factor which can affect the atherosclerosis, this can be the hyperlipidemia, which is considered as a major risk factor. High level of the LDL cholesterol, it is going to carry increased risk of development of the atherosclerosis, whereas the high level of the HDL cholesterol, it is going to give a protective effect. Similarly, the exercise, it is going to give a protective effect because of the increasing the level of the HDL cholesterol. And if a patient is taking the drugs like statin, which is lipid lowering drug, it is also giving a protective effect against the development of the atherosclerosis. The hypertension, it is a major risk factor for the development of the atherosclerosis, especially if the blood pressure is more than 169 by 95 millimeter of mercury. The patient is having the 5-fold increased risk of development of ischemic heart disease. Both the systolic and the diastolic blood pressure, they are equally important, and taking up the antihypertensive drug, it may help in the protection against the atherosclerosis. Cigarette smoking, it is going to again is a well established risk factors both in the male and the female. Using the one pack for several years, it increases the risk of atherosclerosis 200 times, and similarly the cessation reduces the risk substantially. The diabetes, it is also increasing the risk of hypercholesterolemia, increasing the risk of myocardial infarction twice as high. It also increases the risk of stroke, gangrene, and peripheral vascular diseases. Other factors which can affect the atherosclerosis, it includes the homocystinuria, which is a rare inborn error of the metabolism, and increase in the level of the lipoprotein A, stressful lifestyle, type A personality, and the obesity. If the multiple factors they coexist, then they increase the chance of the development of the atherosclerosis. For example, if two major factors are there, they are going to increase the risk of development of atherosclerosis fourfold. If the three major factors are present, the risk of development of the atherosclerosis is up to sevenfold. Now there are two theories regarding the pathogenesis of the atherosclerosis. One is the insudation theory and other one is the proliferation theory. So what about the insudation hypothesis? It was proposed by Virchow in 1856. According to this theory, the atherosclerosis is a form of the cellular proliferation in the intima that results from the increased imbibition of the lipid from the blood. So it is also called as lipid theory. So what is the insudation hypothesis? According to this hypothesis, the intimal cell, they have to engulf the lipid coming from the blood. So this is also known as the lipid theory. The other theory that is known as the encrustation theory, it was proposed by Rokitansky in 1852. According to this theory, the atheroma, this is basically encrustation on the arterial wall from the component present in the blood, forming a thrombi composed of the platelet, fibrin, leukocytes. So incrustation theory, or this is the thrombogenic theory. The current theory, it is basically incorporating the both hypotheses, that is the insudation and the incrustation theories. According to this theory, this is basically the response to injury. So atherosclerosis, it is considered as a response to the injury to the endothelial cells. So this is basically a chronic injury leading to the chronic inflammatory response by the lipoproteins, monocytes, endothelial cells, macrophages, T lymphocytes, and the other constituents of the arterial wall itself. So the main sequence of event in the pathogenesis of atherosclerosis is chronic endothelial injury, which can be subtle one. The endothelial injury, it can lead to the endothelial dysfunction, yielding increased permeability with leukocyte adhesions and thrombotic potential. There is increased chances of accumulation of the lipoprotein at the area of the injured endothelial cells, especially the LDL, which is having the high cholesterol level. So once there is the injury of the endothelial cells, there is the accumulation of the lipoprotein at the area of the injury of the endothelial cells. So there is the modification of these lipoproteins by the oxidation at the site of the injury. Then there is the addition and migration of the monocyte at the area of the injured endothelial cells. They are going to migrate inside the intima, then transform into the macrophages, and they are going to imbibe or engulf the lipoproteins, and they are going to form the foam cells. So in this picture, there is again just a revision of our previous slide. These are the three layers of the vessel wall, that is the endothelium, then there is the muscular layer, and outer one is the adventitia. In the endothelium, there may be the chronic injury because of hyperlipidemia, hypertension, smoking, homocystinuria, hemodynamics factor because of the certain toxin released by the bacteria or viruses, and there may be the immune reactions. So once there is the endothelial injury, it leads to the endothelial dysfunction. These injured endothelial cells, now this becomes a favorite site for the adhesions of the monocytes and the platelets. These monocytes, once they are adhesive to the endothelium, they are going to migrate inside the underlying intima. In the intima, they are going to imbibe the lipoproteins which are circulating in the blood, and these monocytes are going to convert into the foam cells. At the site of the injury of the endothelial cells, now it has become a prothrombotic site. There is the adhesion of the platelets. Once the platelet, these are adhesion, they are adhesive to the endothelial cells. They have become activated, and they are going to cause the release of certain factors which are going to cause the migration of smooth muscle cells from the media into the intima. These smooth muscle cells which have migrated into the intima, they are going to proliferate, and they are going to release certain substances which are going to help in the accumulation of the collagen and proteoglycan in the intima. So there's the enhanced accumulation of the lipid within the cells, that is the macrophages and smooth muscle cells both, and as well as extracellularly. So again, in this picture, you can see that at the area of the injured endothelial cells, there's the adhesion of the platelets, and these platelet and transformed macrophages, they are going to elaborate the different substances which is going to cause the migration of the smooth muscle cells from the media into the intima. In the intima, these smooth muscle cells are going to proliferate and going to secrete the extracellular matrix, leading to the accumulation of the collagen and proteoglycan in the intima. Furthermore, these smooth muscle cells as well as the foamy, the macrophages are going to imbibe the lipids. So they are converted into the foam cells or lipid-laden cells. So what is the final picture of an atheroma? The atheroma is basically an intimal lesion which is having a core which is composed of both intracellular and extracellular fat, and it has certain cells like the lymphocytes, like the foamy macrophages, like the platelets, and like the smooth muscle cells. So again, in this slide, there are the different evolutionary phases of the an atheroma formation. In the initial stage, there is just an accumulation. There is endothelial dysfunction with the accumulation of certain foamy macrophages in the intima, and these foamy macrophages contain the imbibed lipids. Then in the advanced lesion, what is going to happen that there is a central core which is composed of intracellular and extracellular lipids. It has different cellular components including the lymphocytes and the macrophages along with the smooth muscle cells, and it contains the extracellular matrix. And when there is complicated plaque, there may be the hemorrhage in this plaque, there may be the calcification in this plaque. So what is the role of endothelial cells in the atheroma formation? Because of the chronic and repetitive injury, because maybe because of the mechanical denudation, hemodynamic forces, immune complexes in the irradiations, or chemical injury, in the presence of the high lipid, it is going to cause a thickening of the intima. Even non-denuding injury can cause increased permeability and is going to offer the enhanced leukocyte adhesion at the site of the endothelial dysfunction. In humans, the most common causes of the endocrine dysfunctions are smoke, homocysteine, infectious agents, cytokines, tumor necrosis factors, hemodynamic factors, and adverse effect of the hypercholesterolemia. So, what is the role of the inflammation in the atheroma formation? The inflammation, it is going to mediate the process of the atherosclerosis. It is going to cause the progression and its complication. The endothelial injury, that it causes the expression of the adhesion molecule over its surface, that is the VCAM1. It leads to the binding of the monocyte and T cell which migrate into the intima. The monocyte, once they are migrated inside intima, they are going to modify to form the macrophages, then foam cells, and they are going to secrete the interleukin-1 and tumor necrosis factors along with the chemokines, and they are going to elaborate the growth factor for the smooth muscles. The T lymphocytes, including the CD4 and CD8, they are going to complement the action of the macrophages for the release of interleukin-1 and tumor necrosis factor. There are evidence which are going to indicate that the hypercholesterolemia it has a role in the formation of the atheroma. The major lipid in the atherosclerotic plaques, these are basically plasma-derived cholesterol and esters. The oxidized LDL, it is observed inside the macrophages, and once you are going to take the antioxidant, they are going to help in the prevention of the formation of the oxidized LDL formation. If there's a genetic defect in the lipoprotein metabolism, then these patients they have the enhanced or accelerated atherosclerosis formation. The experimental animals which are fed with the high cholesterol diet, they are more chances to develop the atherosclerosis. The epidemiological studies show the correlation between the severity of the atherosclerosis and high lipid level. Lowering drugs which are meant for the lowering of the lipids, they are going to slow the progression of atherosclerosis. The lipid they are going to directly impair the endothelial function, and once the endothelial function is impaired, they are going to accumulate at the site of the injury by introduction of the increased endothelial permeability. These lipids are going to be oxidized by the macrophages, and these oxidized macrophages they are going to stimulate the production of the growth factor and cytokines. Here in this slide you can see that by the ingestion of the fat from the food, the liver it is going to deliver the lipids into the peripheral blood in the form of the VLDL, which is converted into the IDL and then LDL. The LDL it is containing the highest amount of the fat, which is going to delivered into the peripheral tissues. While the HDL it is going to take the cholesterol back from the peripheral tissues into the liver. The smooth muscle cells, these are going to migrate from the media into the intima. They are going to proliferate and deposit the extracellular matrix and converting the fatty streak into the mature fibrofatty atheroma. There are the different growth factors which are responsible for the proliferation and the migration of the smooth muscle cells, and these growth factors are produced by the platelets and the macrophages, and these include the plasma-derived growth factor, fibroblast growth factor, and tumor growth factor alpha. The activated inflammatory and immune cell lead to the apoptosis of extracellular matrix and the foam cells. Now, there is another theory that it's the monoglobal hypothesis. It states that some plaques are monoclonal or oligoclonal. These are equivalent to the benign neoplastic growth. Later research that such patches less than 4 mm are greater in atheromas and in the normal arteries. Another point of interest is that the certain infection with the bacteria and viruses, including the chlamydia pneumoniae and cytomegalovirus, they have a role in the formation of the atheroma. So once again in this picture we are going to summarize the whole process of the atheroma formation. The atheroma, this is an intimal lesion. It is going to caused by the endothelial dysfunction. There are the multiple factors which can cause the endothelial dysfunction. For example, this can be the hyperlipidemias, hypertension, smoking, toxin, hemodynamic stresses, and immune complex reaction, and the viruses. Once there is an endothelial injury, it is going to cause the increased permeability to the forming to the monocytes, and there is addition of the platelet at the site of the dysfunction. Furthermore, once these macrophages are migrated inside the intima, they are going to engulf or imbibe the lipids in the lipid from the blood. They're going to convert into the foam cells, and they're going to cause the oxidation of this lipid. Once these lipids are oxidized, they are going to cause the release of the certain factors and chemokines from these foam cells, which are going to cause the migration of smooth muscle cells from the media into the intima. These smooth muscle cells is further going to cause increase in the size of this intimal lesion by the release of the extracellular matrix component. And finally, there is the atheroma formation, which contains cellular component, extracellular matrix, and the lipid component. Now, how you can prevent the atherosclerosis? There are the primary prevention, which is the control of the modifiable factors, and there is the secondary prevention, which is intended to prevent the recurrence of the events such as the myocardial infarction with the symptomatic disease. The American Heart Association has divided the atherosclerosis into 6 types, starting from the isolated fatty dots, which are the scattered foam cells, then going to form the fibrofatty streaks, then the atheroma, then the fibroatheroma, then the complicated lesions. So here in this picture, you can see on the extreme left hand side, there's a normal artery, and in the normal artery, there's accumulation of the foam cells which are joined together to form the fatty streak. These fatty streaks then slowly progress to form a fibrofatty plaque, which is going to form the advanced or vulnerable plaque, and it is going to occlude the lumen. Now, what is the clinical effect of this plaque? It depends upon its location and its complication. These advanced plaque, these can form the aneurysm, and can form and they can rupture. They can completely occlude the lumen by the thrombus formation, or they can cause the critical stenosis, leading to the clinical sign and symptom when there is insufficiency of the blood flow. So in this picture, you can see this is a cut section of a blood vessel, the coronary arteries, the lumen of which has been obliterated by an atheroma, which is a gray white lesion on the right hand side, and there is the area of the hemorrhage, which is shown in as a red area in the lower picture, which is further complicating this atheromatous plaque. The fibrofatty streaks, these are the earliest lesion of the atherosclerosis, and these are composed of lipid filled foam cells. Then they are going to coalesce and then form a fatty streak. It can occur in the aorta of the children regardless of the geography, sex, and age. And the fatty streak, the relationship with atherosclerosis show that not all the fibrofatty streak they are going to progress to atherosclerosis. Some develop, some don't. So if they develop into the atherosclerotic plaque, it depends upon the association with the other risk factors. So here you can see that in the part A of this figure, you can see that this is the cut section of the aorta, and at the origin of the ostia of the main branches of the aorta, you can see that is the collection of the small yellow fatty areas, which is going to indicate the collection of foam cells in the intima. So why there is the collection of the foam cells in the ostia of the at the origin of the large branches of the aorta? Because of the turbulence of the blood flow in these areas. So you know that the turbulent blood flow, or if there is abnormality in the flow of the blood, it is a risk factor for the development of the endothelial dysfunction. So this area is going to have endothelial dysfunction, and there is the propensity of this area to have the foam cells in the intima. So in the next part, you can see that with the application of the special stain, you can more easily identify the areas containing the foam cells in the wall of the blood vessels. While histologically, you can see that there is a collection of the foam cell just beneath the endothelial layer in the intima of a blood vessel. Atheroma or atherosclerotic plaque, it usually develops in the elastic artery or in the major muscular arteries, and the clinical consequences of an atherosclerotic plaque, it depends upon its location and the severity. It can cause a myocardial infarction, it can cause a cerebral infarction or stroke, it can cause aortic aneurysms, or it can cause a peripheral vascular disease. So now what is the morphology of an atherosclerotic plaque? That atherosclerotic plaque, it consists of a raised focal lesion in the intima of a blood vessel. It is composed of the soft yellow core, which is covered by the white fibrous cap. It is usually 0.3 to 1.5 centimeter in diameter, and they may coalesce to form a larger lesion, and they are usually patchy-one. So characteristically, yeah, they are going to distribute in the abdominal aorta, around the ostia of the major branches, in the coronary arteries, in the popliteal, carotid, and in the arteries of the circus of Willis. I have already mentioned that the component of an atherosclerotic plaque, it consists of cells, that smooth muscle cells, macrophages, and the leukocytes, along with the extracellular matrix, including the collagen, elastic fibers, and proteoglycans, and with the intracellular and extracellular lipids. So here in this diagram, you can see that what is the component and what is the structure of an atherosclerotic plaque. Starting from the above, you can see that there is the endothelial lining, and beneath this endothelial lining, there is a fibrous core which is composed of the smooth muscle cells, macrophages, foam cells, lymphocytes, collagen fibers, and along with the proteoglycans. While its core is composed of necrotic material, it contains the necrotic cellular debris with cholesterol crystals, foam cells, and the calcium. So there is a fibrous cap which is composed of the smooth muscle cells, along with the dense extracellular matrix. Then there's a shoulder which contains the inflammatory cells and new vessels, and core which contains the necrotic debris, along with the cholesterol and cholesterol paste. Again, you can see and that this is a blood vessel containing an internal lesion, that is the atherosclerotic plaque, having the fibrous cap with area of the core, and at the shoulder area on part C of this figure, you can see that there are the new vascularization. These are the vessels which are going to occur as a part of the granulation tissue in the shoulders of the atherosclerotic plaque. The complication of atherosclerotic plaque, these can be calcification, it can be rupture and ulceration and erosion, there can be the hemorrhage, there can be thrombus formation, and there can be the aneurysmal dilatation of atherosclerotic. So in this plaque, you can see a blue area in the right side of this picture, and it is going to indicate the calcification within this atherosclerotic plaque. Again, the thrombus formation, which is completely occluding the lumen of this blood vessels on the surface of it, atherosclerotic plaque. The other complications can be the disruption in the surface of atherosclerotic plaque. This can be the hemorrhage within the plaque. Again, in this figure, you can see that what can be the complication. The atherosclerotic plaque, it can be sudden infarction, it can be the carotid atheroma, it can be myocardial infarction or heart failure, it can be aortic aneurysm or peripheral vascular disease along with the gangrene formation. So the atherosclerotic plaque, it can affect any major part of your body.